Welcome back to NeuraXis Care and Research Center. Let's continue third part with Dr. V.K. Rajoria.
At times it may be less effective if it is the secondary generalized dystonias. As I mentioned previously, the best results are seen when it is the primary dystonia. The speech and swallowing may not improve by deep brain stimulation. This I have already covered. So how we go about it to decide that which patient we can help by doing a deep brain stimulation? The patient needs a very diligent evaluation in neurology movement disorder clinic. Patient also needs a neuropsychological testing. We discuss it among ourselves, and of course I am a neurosurgeon, I am also involved in the decision making, but primarily the decision maker is a neurophysician. And we have a team. You have heard Professor Vinod Puri, he is our neurologist. For psychological assessment, we have Dr. Satya Prakash, we involve physiotherapists also, and I also try to give my inputs that which patient can be operated, and that is how we decide that in which patient we have to go in. Once we decide that we have to plan a DBS, how we go about it? We do a proper pre-operative workup, particularly using the DBS thing. We do a 3 Tesla contrast MRI for the anatomical localization of our targets. Then we do the intraoperative targeting of the desired nucleus, that is by doing the stereotactic MRI. And then we feed this MRI into our planning station, which is in our operation theatre. Stereotactic localization under local anesthesia in operating room, we put the stereotactic frame on the patient's head. We put the stereotactic frame on the patient, and then again we do the CT scan, which is called as stereotactic CT scan. This is how the stereotactic CT scan looks like, which is in the left corner. Then we merge the CT scan, stereotactic CT scan, and the preoperative MRI in the planning station, and we calculate the final coordinates. We also decide our trajectory, that where we have to enter. We have to avoid internal capsule, we have to avoid the ventricles, we try to enter into the gyrus, we try to avoid the major blood vessels. So we decide our trajectory also. Once we have decided our nucleus, once we have decided our trajectory, then we put the another frame on the patient's head, which is called as a stereotactic arc. We also use the CR image for the guidance, and based on these coordinates we make a entry point, we make the burr hole, and then once we have made the burr hole, we pass the micro electrode for the recording. So we have done the anatomical localization, we have done the stereotactic localization, and now we will go for the neurophysiological localization of that nucleus. So the final lead position can be determined by these intraoperative micro electrode recordings. Every area has a different kind of recording. This is the micro electrode recorder, which is in our operation theatre. Through the burr hole we connect to the micro electrode recording. We do not bleeding at that side. There may be small air at that side, so we want the things to settle down, and then we do the programming, that is, we decide for the frequency, the voltage, and the pulse width. So initially the patient has to maybe visit, say, after 1 week of the discharge, then patient visits after 1 month, then patient visits after 3 months, and finally it all depends upon how the patient is behaving. He can visit to the neurologist and neuromodulation specialist. Yes, there are different kind of batteries. Some are for 5 years, some are rechargeable, some are non-rechargeable. Now we have 15 years battery, 25 years battery. There are many types of electrodes, but this all I think is beyond today's topic. Yeah, it is very important that patient and the family should know that what are the risks of the DBS. They should not think that we are doing some magic. We are not doing any magic. This is a surgery which involves the risks, complications and sequelae. About 3% of the patients, according to the world literature, have brain hemorrhage, so they can develop hemiparesis. 5% is the rate of infection, because we are implanting an external thing in the body, and therefore the chances of infection are little high as compared to other surgeries, and therefore we cover them adequately with antibiotics. In some of the patients there can be slurring of the speech, that is dysarthria, but as I told you that during surgery, when we stimulate the neurologist and neuromodulation specialist, they go on checking for it. Sometimes there can be delayed hematoma, behavioral changes, confusion, facial contractions and all that. For the movement disorders, it is more or less a established thing, deep brain stimulation. But at our NeuraXis center, our ongoing thing is to test these deep brain stimulation for other indications like depression, obsessive compulsive disorders, addiction, Alzheimer's disease, and also to try for the newer implants which are coming into the market. So I conclude by saying that DBS is a proven therapy for patients suffering from Parkinson's disease, essential tremor, dystonia, Tourette syndrome and epilepsy. We are also trying now to use it for other disorders like depression, OCD, addiction and Alzheimer's disease. This is an upcoming specialty. It's an exciting technology. There is a continuous improvement. New nucleus are being identified. New indications are also being identified. Yeah, before I show you 2-3 small videos, this slide is very important. You see, a neurosurgeon may talk about implanting the electrode, neurostimulation, so many things, but the most important thing is the diagnosis. You must remember that all tremors are not the Parkinson's disease, and Parkinsonism can be a symptoms of many disorders. So the first step is the proper selection of the case. Now I will show you short videos. I will not take much of the time.